Sanjana, we are good to start. You can start now.
Okay, sir. Good evening, everyone. We are very happy to say that we are back with yet another session of Allergy Forum, which is a case-based discussion platform organized by IAP Allergy and Applied Immunology chapter. We are extremely happy that today we have a very interesting case-based discussion by the team of PGI Chandigarh, and that is on inborn errors of immunity. And the expert for today's session is Dr. Vignesh P. Sir is an additional professor at Allergy Immunology Unit at Advanced Pediatric Center of PGIMER, Chandigarh. And Sir has completed his DM in Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh. And he has been the past secretary of Pediatric Rheumatology Society of India from 2023 to 2025, and he's also the chair of APSID Registry and Research Working Day Party from 24 to 28. And also, he's a treasurer of Indian Society of Primary Immunodeficiencies. Sir is an excellent academician and he has 180 publications to his credit. He's actively involved in various research projects and his interests are primary immunodeficiencies, juvenile dermatomyositis. We're extremely privileged to have you here on this platform, sir, to moderate this session. And next, for the case discussion, we have the DM senior resident, Dr. Dev Desai, who will be beginning today. And he's he's DM senior resident in Pediatric Clinical Immunology and Rheumatology Department of PGI Chandigarh. And the case discussion will be on atopy as a primary manifestation of inborn errors of immunity. Over to you, Dr. Dev, and thank you for joining in, Dr. Vignesh and Dr. Dev.
Yeah, I'll just give a slight introduction before Dave starts. Dave, you can start sharing the screen. So what we have planned to do is Dave will give you flavor of different cases which would emphasize atopy as a predominant manifestation of inborn errors of immunity. And next, Gayatri will take you through how it impacts the management, the atopy and the link between atopy and IEIs. So with this, I think, Dave, you can start your presentation.
Very good evening to everyone. And today I will be discussing about when should we think of inborn errors of immunity in a child with allergies. So first we'll take up two cases. The first case is Master G, a 13-year-old boy from Haryana who had come to PGI for the first time in 2017. He was symptomatic since 1 year of age. So we should note over here that the onset of symptoms was fairly early. And initially he was being managed in the dermatology unit with antihistaminics and remained well for 2 years. From 3 years of age, he came to PGI with history of itching all over the body and pyoderma. After which he became lost to follow-up for a few years. And then he was taking treatment locally in Kurukshetra for 8 years, where skin biopsy was done and reported as epidermodysplasia verruciformis. Then at 13 years of age, for the first time, immunology consultation was sought. Family history-wise, he is born to a non-consanguineously married couple. There is no history of similar skin illnesses or recurrent infections in the family. He is the third-born child. Elder two are sisters who are doing well. He was immunized for age and developmentally normal. On examination at that time, his anthropometry was preserved. The height was minus 1.7 Z-score and weight was minus 1.36 Z-score. His vitals were stable. His heart rate was 90, respiratory rate was 22, and BP was normal. He did not have any pallor, icterus, clubbing, lymphadenopathy, or edema. He had, we'll be showing the picture subsequently, multiple well-defined grayish papules with a verrucous surface all over the body, and multiple vesicular lesions which were small and had a central umbilication suggestive of molluscum contagiosum. The systemic examination was non-contributory. So here we can see those molluscum contagiosum lesions, and here we can see the grayish verrucous lesions which were present all over the body. They were also present on the back, as we can see, and they were itchy. Here we can see the itching marks. So at this point of time, considering extensive warts, early onset eczema, and extensive molluscum contagiosum, underlying inborn error of immunity was thought of. And the first possibility was kept as a DOC8 combined immunodeficiency, followed by hyper IgE syndrome and Wiskott-Aldrich syndrome. We'll be taking up all these disorders one by one later. So basic investigations had shown anemia. The TLC was normal, but there was eosinophilia with an absolute eosinophil count of 984 cells. Platelets were normal. The renal and liver functions were normal. The skin biopsy slides were reviewed, and again they were reported as epidermal dysplasia verruciformis with coexisting molluscum contagiosum. From an inborn error of immunity point of view, firstly, to exclude secondary immunodeficiency, and HIV serology was done, which was non-reactive. The IG profile showed hypergammaglobulinemia with high IgG. IgM was slightly on the lower side, and IgE was very elevated. It was more than 5,000 kilounits of IgE per liter. The T cell subsets which were done, they showed a reversal of CD4 to CD8 ratio. So, in a nutshell, if we say whenever CD4 to CD8 ratio is reversed, it indicates towards a potential underlying combined immunodeficiency disorder. The memory B cells were also reduced. So all this pointed towards a atopic disorder with an underlying combined immunodeficiency. So since hyper IgE syndrome, which is STAT3 dominant negative hyper IgE syndrome, was also on the cards, so TH17 was done. TH17 cells were found to be slightly reduced as compared to the control. Typically, in a STAT3 dominant negative hyper IgE, we find absent TH17 cells. Similarly, pSTAT3, which is also in the same pathway as of maturation of TH17 cells, pSTAT3 expression was also done. That is also typically done to look for STAT3 dominant negative hyper IgE syndrome. That was comparable to control and normal. So we went ahead with the whole exome sequencing, in which two pathogenic variants were identified in DOC8, a deletion in exon 11 and also a deletion in exon 6 and 7. Here we should remember that DOC8 is a gene which is prone to have large deletions. So sometimes a whole exome will miss these, because a whole exome is not a good modality to pick up deletions. So we might have to do MLPA, but in this case, we were fortunate that it was picked up in the whole exome itself. So the patient received topical steroids, retinoids, nicotinamide, and cauterization was done with KOH for the warts. He was started on IVIG replacement and cotrimoxazole prophylaxis from the underlying combined immunodeficiency point of view, and he's subsequently been doing well. Now we come, this was a slightly elder patient. Our second patient is a young, almost infant age, Master R, 14-month-old from Rajasthan. He had a history of eczematous rash all over the body, prominently in the scalp, since neonatal period, purulent bilateral ear discharge since 2 months of age, recurrent diarrhea since 2 months of age, purpuric lesions on the trunk since 4 months of age, and multiple episodes of epistaxis. Family history-wise, he was a second born to a non-consanguineously married couple. The elder sibling is a sister who is alive and well. But importantly, on the maternal side, there was a male cousin who died at 1 month of age due to severe gastroenteritis. On examination, his anthropometry was preserved. He had an eczematous rash on the scalp, trunk, and extremities, ecchymosis and petechiae on the trunk, and a note of hepatomegaly was made. So, considering a history of early onset eczema, almost this eczema had an onset in the neonatal age group with recurrent otitis, bleeding manifestations, recurrent diarrhea, and death of maternal cousin in early infancy, which was pointing towards a probable X-linked inheritance. Wiskott-Aldrich syndrome was high on the cards in this case, and the other possibilities considered were SCID with Omenn syndrome and HIV. So he was worked up for the same. He had anemia, he had eosinophilia, and importantly, he had thrombocytopenia, for which a peripheral blood smear was also done. But because the platelet count was very low, it was not possible to accurately comment on the mean platelet volume. Urea and creatinine, the renal function tests and the liver function tests were normal. The CRP was elevated. From the immunological point of view, firstly, as always, secondary immunodeficiency was ruled out. HIV serology was non-reactive. IG profile was normal, but there was high elevation in IgE, which was 6.42 kilounits per liter. A lymphocyte subset showed reduced proportions of CD3 and CD19 cells, which are the T and B cells. And then T cell immunophenotyping was done. In this, we could see that the CD4-CD8 ratio was normal, but the naive cells, which are the CD45RA positive, proportions were reduced in both CD4 and CD8 lineages, and memory cells were increased. This is something typically we see in combined immunodeficiencies and especially Omen syndrome. We'll be taking this up later. So a whole exome sequencing was done, and as expected, we had our first differential was a Wiskott-Aldrich syndrome. So that is what was revealed in the exome also. In exon 4, there was a hemizygous pathogenic variant which was there in the Wiskott-Vas gene. So now we'll come to the discussion. We have had 2 cases. So typically we are trained to think that if there is an inborn error of immunity, the main manifestation will be recurrent infections or severe or atypical infections. But now, as our understanding of IEIs evolves, it is increasingly becoming clear that IEI is a wide spectrum of disorders which can have infections on one hand. There can be lymphoproliferation, that is hepatosplenomegaly, lymphadenopathy, malignancy, autoinflammation, autoimmunity, and even atopy or allergy is an important arm of this spectrum of IEIs. So it sounds a little counterintuitive that why somebody with a deficiency in immunity should also have atopy. Because on one hand, there is inability to mount effective immune response to the pathogens. But on the other, we are also seeing an exaggerated allergic immune response to the harmless allergens. So this list might look a little complicated. I don't think we need to remember all of this. But yeah, here we have just elucidated some of the mechanisms which will be subsequently be elaborated upon in the second presentation of IEIs which predispose to atopy. Firstly, if there is a disrupted epithelial barrier, these are all genes which contribute to the maintaining integrity of the epithelial barrier. If that is disrupted, then understandably there is an increased risk of atopies. Granulocytes, we should remember basophils which release histamine are also granulocytes. So if there is atypical granulocyte regulation that is seen in KIT, PLCG2 and EDGRE2, we will see atopic manifestations. They are typically urticaria which is seen. Then Wiskott-Aldrich syndrome, Wiskott-Vas gene, DOC8, they are all a part of the pathway which does the actin cytoskeleton remodeling, which is an important role in the development and activation of the immune cells. So even there we see atopies. If there is defects in the antigen receptor signaling, as there are in CARD11, CARD14, MALT1, there also we have a predisposition to atopy as well as an underlying immunodeficiency. SCID with Omen syndrome, where there is oligoclonal T cell expansion, typically with RAG1, RAG2, and ADA gene defects. There also we have atopy as well as profound immunodeficiency. The prototype of atopic disorder, atopy in IEI typically used to be Job syndrome. That is now known as STAT3 dominant negative hyper IgE syndrome. And then there are other genes like IL6R, IL6ST, which also have a similar presentation. And CARD11, MALT1, and PGM3 are other genes which are also having atopy and IEIs together. So we will take up some of the these disorders now in the upcoming slides. So firstly, since atopy is fairly common in childhood, we should know that when should we think of an underlying inborn error of immunity in a patient with atopic diathesis, because for that then we might need to work up further, as it will have important ramifications for the prognosis and treatment of the child. So typically, if there is early onset, especially in the neonatal age group or in the first few months of life, like we saw in our second case, then we should be alerted that this could be an underlying inborn error of immunity in the child. Because atopic dermatitis typically begins around 3 to 6 months. Even if it is early onset, it begins by 3 to 6 months and is common in the first 2 years of life. But if there is neonatal onset of atopy, then this is a big red flag for an underlying IEI. If there is severe recurrent atopy which is poorly responding to conventional treatment, then again we should rethink that if it is just a simple atopy or there is something else which is underlying. If there are very high level of Th2 biomarkers like serum IgE and eosinophilia, then again it warrants evaluation. We must carefully look for other evidence of immune dysregulation. As I said, now inborn error of immunity is a broad spectrum which has susceptibility to infections, autoimmunity, lymphoproliferation, autoinflammation. also which can be there. So we should look for those signs and symptoms in the patient, and if they are present, then we should work up for an underlying inborn of immunity. If the child has short stature, failure to thrive, associated skeletal dysmorphisms, neurodevelopmental delay, or other syndromic features, then again it is a red flag which should prompt further evaluation. And like we saw in the second case, if there is any family history or other affected family members or history of consanguinity, again an underlying IEI must be worked up for. So this is again we have shown in this pictorial format that severe and or early onset atopic disease with one or more of these features like very high IgE or eosinophilia, recurrent severe infections, growth failure, short stature, connective tissue abnormalities, neurodevelopmental delay or other syndromic features, malignancy, autoimmunity, or other symptoms of signs and symptoms of immune dysregulation. If they are present, then we must work up for an underlying IEI. So now we'll take up some of the individual inborn errors of immunity which predispose to atopy. So firstly, hyper IgE syndrome, typically used to be called as Job syndrome in the past. There is triad of early onset eczema, recurrent skin and subcutaneous infections, and cold abscesses. By cold abscesses, we mean there will not be prominent features of inflammation like fever, pain, and even the inflammatory parameters like CRP are typically low in children with STAT3 dominant negative hyper IgE syndrome. They also have dysmorphism in the form of pore spaces, a broad nasal bridge, thick eyebrows, high arched palate. They have hyperextensibility, scoliosis, and tendency to develop fractures with trivial trauma. They also have underlying vascular abnormalities which predispose to aneurysms. And typically, they have recurrent episodes of pneumonia which will not have very prominent fever or inflammation, and will leave, if we do an X-ray, we can see pneumatoceles. So genes, the prototype gene is STAT3 dominant negative, but there are also other genes like ZNF341, IL6ST, and IL6 receptor, which can present with a similar phenotype. DOC8, earlier, DOC8 was considered as an autosomal recessive hyper IgE syndrome, but in the latest classification, it is categorized as a combined immunodeficiency. It has a presentation which is in some ways similar to a STAT3 dominant negative hyper IgE. There are subtle differences like dysmorphism, the skeletal features, etc. are less prominent. There is a higher risk of anaphylaxis and food allergies. And unlike the STAT3 dominant negative hyper IgE, there is a predisposition to cutaneous viral infections like refractory molluscum and warts, like we saw in our first case. On immunological workup, we see virtually absent switched and memory B cells. IgG is normal to high, IgA is normal, IgM is low. So even in our first case, we saw that IgE was on the higher side and IgM was low. And early hematopoietic stem cell transplant should be considered in these children because they are at a high risk of morbidity and mortality due to the underlying immune deficiency. Wiskott-Aldrich syndrome, that is classical, has a triad of early onset eczema, bleeding manifestations with microthrombocytopenia. By microthrombocytopenia, we mean the platelets are low and the mean platelet volume is on the lower side. And immunodeficiency. They have increased susceptibility to bacterial and viral infections, typically cytomegalovirus, Epstein-Barr virus, human papillomavirus, molluscum, etc. can be seen. They also have increased risk of autoimmunity in the form of autoimmune hemolytic anemia, vasculitis, arthritis, nephropathy, inflammatory bowel disease, and typically the inheritance is X-linked recessive. As we saw, there was X-linked history in our second check. IPEX or immune dysregulation polyendocrinopathy, enteropathy, X-linked. There is defect in the survival or function of the Treg cells. There is severe eczematous dermatitis with early onset type 1 diabetes mellitus, autoimmune thyroiditis. There is chronic diarrhea and features of immune dysregulation in the form of autoimmune hemolytic anemia and thrombocytopenia, which we call as EVAN syndrome, autoimmune hepatitis, nephropathy, and myopathy. And they are predisposed to severe bacterial, fungal, and or the viral infections. Cadence, which is CARD11 associated atopy with dominant interference of NF-kappa B signaling. There we see severe atopy in the form of atopic dermatitis, asthma, eosinophilic esophagitis, food allergies, rhinoconjunctivitis, along with recurrent respiratory tract infections and cutaneous viral infections. There is high IgE and eosinophilia with hypogammaglobulinemia, and a similar presentation can also be seen with MALT1 loss of function mutation. Omen syndrome, it is a subset of severe combined immunodeficiency or SCID. There is erythroderma or neonatal eczema along with lymphadenopathy, hepatosplenomegaly, eosinophilia. They have a susceptibility to severe atypical bacterial, fungal, and viral infections. There is a whole range of genes which can be involved, but the most common ones are RAG1, RAG2, ADA, and IL2RG. IL2RG is the gene for X-linked SCID. And early diagnosis in these cases is of utmost importance because they require a hematopoietic stem cell transplant at the earliest, short of which they might succumb to the infectious complications. So my take-home messages for today are that inborn errors of immunity span a broad spectrum, out of which atopy is an important arm. Early onset, difficult to treat atopy could be a clue to an underlying inborn error of immunity. And other features of immune dysregulation like lymphoproliferation, autoimmunity, etc., should actively be looked for in such patients and prompt further evaluation for inborn errors of immunity. Thank you.
Yeah, thank you, Dave. I think that's a comprehensive overview of inborn errors of immunity with atopy as a predominant manifestations. So, Dr. Shenchana, do we have can we take any questions now?
Yes, sir. Yes, sir. We can take the questions, sir. If any.
Can I
Right
ask?
now,
Yeah,
yes, sir.
yes.
Yes, so in case 2, when he was presenting, so it was treated with IVIG. And when the investigations were shown, then at that time the IgG levels were on the higher side. So means like in this particular case, how giving IVIG is helping the child, by what mechanism?
Yeah.
Uh,
Dave, you
Thank
want
you
to
very
take
much,
up?
sir.
Yeah.
Yes. Thank you very much, sir. That was a very pertinent question, and this is something which is often a source of confusion. So we must remember that when we are doing the IG profile, we are only estimating the quantity of the immunoglobulin which is present and not its functionality or quality. Like even if we see, just to give a crude example, even in patients of HIV, we see very high immunoglobulin levels. That is, hypergammaglobulinemia is seen. But whether those immuno antibodies are actually functional or protective or not is a totally different question. So for that, typically we can do functional antibodies. Like if a child has been vaccinated, we expect the child to have protective antibody titers. So we can test the functional antibodies to see if they are protected or not. And typically, even in these IEIs like Wiskott-Aldrich syndrome, if there is hypergammaglobulinemia, mostly it is not protective and functional. So when we are giving IVIG, we are giving a pooled IgG from healthy donors, and we expect that it will confer protection to routine infections in the child.
Thank you. Thank you very much. Thank you.
Yeah, thank you, Dave. So I think for clinicians, I think there are 3 important messages which I want to convey here. So 3 most common IEI which presents with atopy are the STAT3 dominant negative hyper IgE syndrome, that is otherwise called Job syndrome. The second one is the Wiskott-Aldrich, and third one is the Dockade deficiency. So Dockade deficiency and Wiskott, they have T cell problems. So they present with combined immune deficiency. In Dockade, you can have refractory molluscum, you can have epidermodysplasia verruciformis, so warts, molluscum, oral thrush. So these are all T cell problems. So whenever we have eczema with T cell problems, it is usually Dockade or Wiskott. In Wiskott, thrombocytopenia is a big clue, and autoimmunity will be predominant, like Evans syndrome, autoimmune hemolytic anemia, or colitis. So those things would be prominent in Wiskott-Aldrich. Whereas STAT3 dominant negative hyper IgE syndrome is a kind of a phagocytic defect. Though there is eczema, there is a typical predisposition to staphylococcus infection. So recurrent staphylococcal boils, pneumonia with nematocele formation, and phenotypic abnormalities like hyperextensibility, coarse facies, or delayed fall of the teeth. So these could be the clues for the STAT3 dominant negative hyper IgE syndrome. So that is number 1. Number 2, primary atopic disorders, that is IEI with predominant atopy, that is otherwise called primary atopic disorders, and hyper IgE syndrome should not be confused. Hyper IgE syndrome, HIES, means a triad of 3 important manifestations: the eczema, recurrent staphylococcal infections, and phenotypic abnormalities. The prototype defect is the STAT3 dominant negative. There are 2-3 more genes which Dave has shown in his presentation. So hyper IgE syndrome, the term should not be used loosely for any child with high IgE levels. And with that, I think we'll move to the next presentation by Dr. Gayatri. I think she will highlight the mechanisms of how atopy develops in IEI and how it translates to the management approaches which we follow in these patients. So I think Gayatri, with that, I think you can start your presentation. If we have any more questions at this point, we can take. We have 2-3 more minutes.
Yeah, there are no questions in the chat box as of now, sir.
Okay.
So,
thank you, sir. And thank you, IAP, for giving us this opportunity. So the second presentation today would be on the diagnosis and targeted treatment of primary atopic disorders in childhood. So why should we consider an inborn error of immunity in a child with allergy? Because not all severe allergies are just allergy. They might be a subset of primary atopic disorders. And allergy might be the initial presenting manifestations even before recurrent or severe infections appear. So by suspecting an inborn error of immunity in children with severe refractory recalcitrant allergy, we can have an early diagnosis, and that enables targeted treatment, and it can prevent years of complication and morbidity. So the inborn error of immunity, commonly now known as the primary immune deficiencies, are considered synonymous with recurrent infections, persistent infections, or unusual infection. However, it is just the tip of the iceberg, and most of them can present with lymphoproliferation, autoimmunity, and severe refractory allergy also. So we need not wait till the infections develop to identify an underlying inborn error of immunity. So how do we differentiate between a commonly occurring polygenic allergy and a monogenic allergy? So the common typical allergy has a multifactorial etiology, where various genetic and environmental factors play a role. They will usually have mild to moderate disease, though they can have elevated IgE and eosinophil levels. These children are generally healthy, and they maintain appropriate growth, and they do not have other systemic features. They don't have other non-atopic features, and they usually typically respond very well to the conventional treatments like antihistaminics and corticosteroids and moisturizers and emollients. However, in case of monogenic allergy, the allergic manifestations are very severe, and they can have elevated IgE and eosinophil. However, along with these manifestations, they also have the propensity to develop autoimmunity, malignancy, and infection, and they can also develop connective tissue abnormalities. So these children typically they have an early onset, and they can have short stature, they falter growth, and they can present with failure to thrive. So, and the allergy in these patients are usually persistent, refractory, and they are less responsive to the conventional therapy. So what happens in case of an allergy? Normally, on encountering an allergen, the first line of defense is the antigen presenting cell. It will encounter the allergen. It will ingest it. It will digest it, and will take to the lymph node, where this dendritic cell will present to the naive T cells a small peptide of this allergen. And on presentation, this dendritic cell will also stimulate this helper T cells and convert them to the Th2 subtype of lymphocytes. And on conversion of the Th2 type, they start producing IL-4, 5, and 13, which will promote the formation of IgE. It will attract eosinophils to the site of allergen exposure. So these Th2 lymphocytes, some of them they reside in the lymph node, and some of them they reach the skin, and as a Th2 tissue resident memory cells, and these cells will remain in the tissue, And whenever they are re-exposed to allergen, they keep on secreting IL-4, 5, and 13, so increasing the allergic manifestations, and this leads to epidermal hyperplasia. So we have seen various red flags which are described in the previous presentation. So we'll go through each of these red flags and what is the underlying pathophysiology, and we'll go through each in detail and what investigations can be done and how to identify them earlier. So the first red flag which was described was early onset neonatal erythroderma with ichthyosis, refractory eczema, and failure to thrive, and severe, in some cases, severe food allergy. So this is a child with a Netherton syndrome. Here we can see severe erythroderma, neonatal onset ichthyosis, and refractory eczema. So this kind of presentation is typically seen in defects in the components of the skin. Mainly the tight junctions are formed by the desmoglein protein, the corneodesmosin proteins, and these desmosomes are regulated and are presented on the cell surface through the SPINK5 gene. And the filaggrin ensures hydration of the skin surface. And any defect in this will lead to a defective skin and mucosal barrier. It will lead to increased permeability to allergens, and it will lead to activation of Th2 cytokines as described earlier, and it lead to chronic allergic manifestation. So the typical prototype of this disorder is the neck-formal Netherton syndrome, which is caused by defect in the SPINK5 gene. So we have other genes like the filaggrin, desmoglein, corneodesmosin, and CAR14. So they typically present with early onset erythroderma, ichthyosis, pruritus, and they will have typical hair anomalies. So how do we make a diagnosis of Netherton syndrome? By a simple hair microscopic examination, which can be done at the bedside by just cutting the hair shaft and just seeing them under the microscope. We can see this bamboo hair shaft, which is called as Trichodexis invaginata. So this we can see a protruding structure in the shaft of the hair. This is called as a bamboo hair shaft appearance. This gives us a bedside diagnosis of Netherton syndrome. So the second red flag is urticaria, which is not responsive to the routine antihistaminics, and these urticaria sometimes can be triggered by cold exposure, and along with that there can be systemic inflammation in the form of fever and presence of recurrent infections. The recurrent infections can occur later, as mentioned earlier. So this occurs because of defective mast cell degranulation. So as we saw earlier in the pathophysiology, so once the Th2 cells are stimulated, they will produce IL-4, and this will cause the B cells to produce IgE, and this IgE will be recognized by the mast cells, and it will lead to mast cell degranulation. So when this process happens, in the downstream of this recognition of IgE and degranulation of mast cells, we have a lot of immune complexes, and one such protein is called the PLC gamma. So a defect in any of this process can lead to defective mast cell degranulation and abnormal triggering of this mast cell degranulation by simple triggers like cold exposure. So here in this picture, we can see the urticarial lesions and the vesiculobullous eruptions, and this has occurred in this patient after exposure to swimming pool or any cold trigger. So here there is aberrant mast cell activation, which is triggered by cold, and this has led to, this usually leads to urticaria, and also systemic features of inflammation in the form of fever, and they are hypersensitive to cold and vibration, and these are typically called as autoinflammatory disorders, and the genes involved are the commonest one being the NLRP3 and the PLC gamma 2. Sometimes some of these disorders like the PLC gamma 2 might be associated with recurrent infection. However, it might not be the case always. So the next red flag is the neonatal onset erythroderma, just like the first case. However, there need not be extensive ichthyotic erythematous lesion. However, apart from erythroderma, they might have failure to thrive, generalized lymphadenopathy. There can be hepatosplenomegaly with or without infections. So this typically occurs in women's syndrome. So what is women's syndrome? So the T cells initially, when they are formed in the primary lymphoid organs, they get trained in the thymus. So in the thymus, the cells which are after training, they are released into the circulation as naive T cells. So before they are released into the circulation, there is a process within the thymus which makes sure the T cells are not reactive against self antigens. If they are going to be reactive against self antigens, the cells are killed then and there. And only when they are not reactive to self antigens, they are released into the circulation, and they are subjected to activation by various other antigens which will be encountered further. However, if there is any defect in any of the T cell during the T cell development, or in the exposure to the self antigen, if there is defect in any of these processes, there can be formation of autoreactive T cells which can act against self antigens, and the T cells thus formed may not be having a very diversity, and most of them can be acting against self antigens. So this typically occurs in type of severe combined immunodeficiency called Women's syndrome, typically caused by a defect in RAG enzyme or the ligase 4 or FOXN1 or PAX1 gene. And here, because of oligoclonal T cell expansion due to defective thymic selection, there can be TH2 skewing of the cells. There can be excessive TH2 skewing, leading to increased levels of IL-4, IL-2, IL-30, and increased allergic manifestation. So they typically present as neonatal onset erythroderma, and there can be leathery skin as seen in this picture. And as a part of infection, they can also have diarrhea, and they'll be failing to thrive. And they typically, despite being a kid, they can present with hepatosplenomegaly, generalized lymphadenopathy. And typically, as seen in this picture, we can see there can be alopecia, and in this picture, we can see the loss of eyebrows, which is typically manifestation of this Women's syndrome. The next red flag is neonatal eczema. With autoimmune endocrinopathies like neonatal onset diabetes mellitus, thyroiditis, and with or without persistent infections. So here, once, as we saw initially the pathophysiology, once the T cells are activated in the lymph node, they have to reach the site of allergen, or reach to the site of immune response. So for them to reach, they to prevent overactivation of the T cell response, we have certain cells in our body called the T regulatory cells. These prevent excessive T cell activation, so that the immune activation per se does not lead to disease manifestation. So if there is any defect in the T regulatory cell, like these T regulatory cells typically express a receptor called IL-2 receptor, and they are stimulated by IL-2, and they express an inhibitory receptor which prevents T cell activation called the CTLA4. So, and they typically express a transcription factor called FOXP3. So any defect in any of these components which are part of the T regulatory cells, which regulates the immune response, can lead to early onset autoimmunity as well as neonatal onset eczema. So here, because of impaired T regulatory function, there is uncontrolled autoimmunity and allergy. And the typical genes are the FOXP3, which leads to the syndrome called IPEX, and the IL-2 receptor A or the CTLA4 defects can lead to this type of defect in peripheral tolerance. So they present with infantile onset or neonatal onset eczema, and multiple enteropathies like the diabetes and thyroiditis. They can have enteropathies presenting as life-threatening diarrhea, and they may or may not have infections at the presentation. The next red flag which we'll be seeing is a child presenting with early severe eczema, and along with that, child having viral infections with bleeding tendencies and autoimmunity. So here we can see, as we see, we have a severe viral, we have severe eczematous lesions, and we can see the molluscum lesions with the umbilicated center, and these are very itchy, and the child has bled in many sites. So this is typically a defect in the actin. It is a defect of actinopathies. So here, for the T cells to migrate to the site of infection or to the site of allergen response, the T cells have to migrate from the place of stimulation to the site of the elicitation of the immune response. For the T cells to migrate, we need the actin assembly. So any defect in this actin assembly might lead to defect in T cell migration, which can lead to defective immunity, defective response to microbes, also defective and exaggerated response to allergens. So here, because of defective T cell activation and migration, it can lead to combined immunodeficiency and severe atopy. So they usually typically present with very extensive viral skin infections. They can have eczema with or without severe infections and autoimmunity. So this was a typical prototype which was seen described in the first case in the previous presentation. So the DOC8, Wiskott-Aldrich syndrome, and the ARPC1B and CARMEL2 are some genes which are part of which are involved in the downstream TCR signaling. So the next, the final red flag is very high IgE levels, more than 2000 kilounits, peripheral eosinophilia, with or without recurrent infections and skeletal connective tissue anomalies. So this here, this disorder affects mainly the IL-6 mediated downstream regulation. So the downstream pathway of IL-6 is affected, which leads to defective TH1 and TH17 signaling. So perceived because of defective TH1 and TH17 response, these cells are skewed towards development of TH2, leading to excessive allergic manifestations, leading to excessive production of IL-4, 5, and 30. So this can occur because of a defect in any of these proteins like the IL-6, the GP130, or the STAT3, or the ZNF341, any of the defects. So even if you don't remember, we don't have to remember the gene names, but what we have to remember is the typical skeletal abnormalities which is seen in these patients. So apart from having very high IgE and peripheral eosinophilia, some of these patients might have skeletal abnormalities. As mentioned earlier, they can present with retained primary dentition, which can be seen in older children, or extensive hyperextensibility, which can be seen in younger as well as older children, and they can be pathological fractures. So they can have recurrent staphylococcal infections leading to pneumatocoel formation, and there can be severe eczema. So this occurs because of aberrant cytokine signaling, which leads to impaired immunity and TH2 skewing. And this typically encompasses the hyper IgE syndrome, which includes all the defects in the downstream signaling of the IL-6. And here they typically present as a severe eczema, recurrent staphylococcal infections with skeletal tissue abnormalities. They might have coarse species, and the staphylococcal infections are typically cold. They are not warm to touch. They don't want fever. They don't have CRP response. So they reach hospital early, especially in Indian settings. And when we see them, they can be failing to thrive also. So with only they'll be getting treated as only eczema. It is by just recognizing on simple physical examinations to look for hyperextensibility and coarse species, and asking history for retained primary dentition, we can it can give us a clue towards diagnosing these defects. So again, summarizing all the red flags. So severe extensive atopic dermatitis, which is especially infantile or neonatal onset, or when the eczema or the allergy is refractory or resistant to standard treatments, and when there is severe multiple food allergies in early onset in life, recurrent unusual infections like bacterial, viral, or fungal or other opportunistic infection, and when there are autoimmune manifestations, when the child is failing to thrive, and when the child has other syndromic features like hair anomalies, skeletal tissue defects, and dysmorphic facies, and very high serum IgE and marked eosinophilia, with positive family history or consanguinity, we must think of something more than simple allergies. So this is a flow chart which is given recently from a good center in Germany. So they say that in any patient, in a general population who have asthma, atopic dermatitis, rhinitis, or keratoconjunctivitis, if there are, we have to look for these red flags. If there are any of these red flags, we have to go ahead and further perform further investigations. If there is one red flag, at least a simple investigation like some complete blood count, which can give us idea about the eosinophil levels and the elevated IgE levels might help. And if there are two or more red flags in settings wherever available, in any academic centers or in centers where commercial labs are available, we have to go for further immunological assays to rule out underlying inborn error of immunity. And if not, whole exome or a whole genome sequencing might help us give us a diagnosis. And so what are the immunological investigations which have to be done? So in the first red flag, which was seen as in case of as a woman's syndrome, here Simple investigations which are available everywhere include the complete blood count, which can have eosinophilia. There might or might not be lymphopenia, which is seen in a typical skin. So even with a normal lymphocyte count or a higher lymphocyte count, this can present. So a lymphocyte subset and naive and memory T cell subsets are nowadays are being available in a lot of commercial labs, and immunoglobulin quantification is definitely available across the country. So this simple investigations can help us give us a clue towards the underlying diagnosis of Women's syndrome. Here, typically, there is oligoclonal T cell proliferation, very high IgE levels, and very low naive T cells. So, this is an investigation which is done in our center. So, here we can see that though the T cell numbers are high, the 4:8 ratio is preserved. However, the naive T cells, which are expressed by the marker of CD45RA, is very less than 1%. And all the cells are in the memory compartment, which is denoted by the marker RO. So this is typically seen in a patient with Women's syndrome. And this is further confirmed with the further investigations like HLA-DR, which is a marker of activated T cells. And this is a T cell repertoire which is performed by flow cytometry. Here we can see that there is expansion against one particular group of antigen here, so denoting the oligoclonal T cell expansion. So the next phenotype is the hyper IgE syndrome. Here again, simple, apart from the clinical clues like the hyperextensibility, the core species and retained primary dentition and the skeletal abnormalities and pathological fractures, simple clues which can give us a diagnosis as a complete blood count, which can show eosinophilia, very high IgE levels, and in places which are wherever available, TH17 quantification and STAT3 phosphorylation assay can be done. If not, a naive and memory T cell, which is now available in various commercial labs, can be done. Here, typically, the TH17 levels are low, the IgE levels are very high, and there is a reduced STAT3 phosphorylation. So this is again an image showing the TH17 cells and the reduced phosphorylation of STAT3, which is seen in a patient with hyper IgE syndrome. Next subset is the IPEX-like syndrome. Here, which is a defect of peripheral T cell, a peripheral tolerance defect. So here the T regulatory cells are low, and the naive and memory T cells can be deranged, and it can be these tests can be available in various commercial labs. So this is again the T regulatory cells which are which have been performed in the control and in the patient. Here we can see a very low T regulatory cell in a patient with a defect in IL-2RA. So we then have the other actinopathies. Here, especially in Wiskott-Aldrich syndrome, the typical triad of Wiskott-Aldrich syndrome is a male child presenting earlier with eczema, recurrent infections, and microthrombocytopenia. So here, low platelets can be a clue. Something as simple as a peripheral smear can give us a clue of the underlying diagnosis. Here, the peripheral smear can be done as early as within 10 to 15 minutes of withdrawing the sample, can give us, in the smear, we can see small platelets. So, and most of the times it does not have any other differential diagnosis other than Wiskott-Aldrich syndrome. And a simple test like an immunoglobulin profile can give us a clue regarding the underlying defect. Next come the CBMopathies. Here, the specific antibody responses, immunoglobulin levels, and B cell immunophenotyping can give us clue. So, this is the flow cytometric expression of VAS protein expression, which is done in our lab. Here we can see there is a reduced expression of VAS protein expression in a child with Wiskott-Aldrich syndrome. So other manifestation can be eosinophilic gastroenteritis. They can present with food allergies. However, when any of the red flags are present in any of these patients, it is always better to go ahead with immunological assays whenever possible. And whenever there is a red flag, whenever the atopy is atypical, it is even if these investigations are not available, referring to a better center or if whenever possible, trying to do these investigations or a whole exome sequencing might help. So how do we manage these children with IEA who present with atopy? So unlike a typical allergy, which can be managed by pediatricians and allergists, this might require a multidisciplinary care, and early diagnosis can can follow tailored targeted specific treatments. So, and there has to be measures which have to be taken for infection prevention and immune restoration also. So how does it differ from the typical management of typical allergy? So we don't, in a standard typical allergy, we give only emollients, corticosteroids, antihistaminics, and other therapy. However, in patients with underlying inborn error of immunity, the patient has to be on antimicrobial prophylaxis, which can prevent further infections, and these infections can further aggravate the atopy. So managing, giving the antimicrobial prophylaxis plays a crucial role. And then immunoglobulin replacement therapy. So here again, as described in the previous presentation, passive immunity reduces the infection-driven inflammation, and there can be dietary management in cases of enteropathy in a patient with underlying IEI. So this is a recent report. I mean, we can see monoclonal antibodies being used in patients with underlying inborn error of immunity. So this patient initially had a very high SCORAD score, and after treatment with dupilumab for 3 months, her eczema is completely resolved. So the targeted therapies which are used in inborn errors of immunity with underlying atopy include dupilumab, omalizumab, mepolizumab, ustekinumab, and JAK inhibitors, and finally the curative option being gene therapy and HSCT. So dupilumab is usually used in patients with hyper IgE syndrome, STAT3 or STAT3 hyper IgE syndrome or docket defect. In typical allergy, it is reserved for moderate to severe atopic dermatitis and asthma. And in omalizumab, it is used in conditions with elevated IgE levels. Again, it is still FDA approved for use in refractory asthma and chronic urticaria. However, other monoclonal antibodies like the IL-5 inhibitor, like the mepolizumab or the ustekinumab, are not used in standard typical allergies. They are indicated in conditions like Netherton syndrome or CBMopathies, where there is an elevated levels of IL-5 and IL-12, IL-23 axis. And JAK inhibitors are used in conditions with a gain of function mutation in the JAK-STAT pathway, and these are again not part of the routine allergy, standard allergy treatment. So the curative option in these patients would be gene therapy or stem cell transplant, where definitive correction of the severe IEI with atopy can be achieved. So hematopoietic stem cell transplant is always recommended in patients with severe IEI with atopy, and gene therapy is a novel option, though at present it is not available in India. It has been tried in other parts of the world, and enzyme replacement can be tried in certain inborn error of immunity, like the ADAs kid or the PGM3 deficiencies, where they can provide us a bridging therapy, from the diagnosis to the hematopoietic stem cell transplant. So the key differences between the management of a conventional typical allergy and the atopy in a child with underlying inborn error of immunity would be to identify the root cause, and these are usually refractory, so they may require targeted therapy with monoclonal antibodies or the JAK inhibitors, and these can be used as a bridging therapy to the final curative options like HSCT. So whenever there are 2 or more red flags, there can be underlying. We have to intensify the workup by doing underlying immunological evaluation and doing a genetic evaluation in the form of whole exome sequencings. And these patients, without treatment, they may develop frequent infections, autoimmunity, and malignancy, leading to morbidity and even mortality. So whenever we have red flags, we should try to look for the underlying root cause, and with the multidisciplinary teamwork, we might be able to manage these patients and start them on antimicrobial prophylaxis and IG replacement. And biologics can be used to bridge the therapy from the diagnosis to the final transplant. And these patients should always be counseled for curative stem cell transplant and gene therapy. Thank you.
Thank you, Dr. Gayatri. May I invite Dr. Vignesh for his comments or any?
Yeah, I think Gayatri has given an exhaustive overview of mechanisms and therapeutic options. You can stop sharing your screen, Gayatri. Yeah. So we can take up questions if you have any. from YouTube chat box? Do we have any?
We
No,
do
sir.
not have
Right now,
any questions there.
there are no questions as such.
Okay.
So, thank you, Dr. Gayatri and Dr. Dev, for that very well structured and insightful case presentation, actually, which highlighted very important points for both pediatricians and allergists. We actually truly appreciate your clarity and depth in which you dealt with this topic, and it was very informative. I would like to invite Dr. Neeraj Gupta, sir, President of IEP Allergy and Applied Immunology Chapter, for his comments. Sir is always helpful and always guiding us through all our this one, and he's leading from the front when as a president this year.
Thank you, Sinchana. And I think it was a wonderful session. And I must admit that both of you, both Dr. Dev and Dr. Gayatri, has really come forward with the needs which we actually needed. That means many a times when we are keeping these sessions, so the speaker usually drift towards immunodeficiency per se rather than touching upon the allergic problem. But you actually hit the nail from the head. That means like a child who is presenting to us, very common presentation atopic dermatitis, very common presentation eczema, and where we are faltering. So you actually picked that point with the examples of the different case discussions, and which I really liked, which I really loved. Few messages whenever a patient who is not responding, he is not typically behaving. It is like abnormal age group. You feel that there is something which is going abnormal, which is not in the normal bracket. Then it is always better to consult with your colleague, could be your dermatologist or rheumatologist or immunologist. So I think a very nice, crisp message which you have given. So I'm very much thankful to you. And definitely, I'm very much thankful to Dr. Vignesh for moderating this session. And thank you so much for always trying to find out some time for us, for our chapter, to help us to learn more and more. So thank you. Thank you so much for all three of you. Thank you.
And thank you, IAP Allergy and Applied Immunology chapter, for giving us the opportunity. We also enjoyed the session.
No, we love actually your company and we would like to have more sessions. So we will be having one webinar series which we are planning, I think somewhere in October first week or so. And that webinar series will be applied immunology webinar series. So I will be coming back to you once again for drafting the program. And so this is apart from the PID which I am talking about. So
Okay.
in this, we will be having a webinar series and we definitely require your help for that to draft the program and then to, you can say like sequentially follow the things from ABC onward so that we can also, our colleagues can also learn and when to refer, whom to refer, what to do. So we can do these things. So that will be great. Thank you. Thank you so much.
Thank you.
Thank you,
so
Dr.
much.
Vignesh. Thank you, Dr. Gayatri,
Thank
for
you,
an excellent
Dr.
session.
Sinchana.
Thank you,
Thank you,
Mr.
Neeraj, sir.
Thank you for giving this